Hello, everyone, and welcome to Boston Children's Hospital's Heart Center's webinar series for the Biventricular Repair Program. Today, we'll be discussing the routine EP conduction mapping work that we do here at Boston Children's Hospital, where we have become a leader in biventricular repair procedures. First, I wanted to start off with some introductions. My name is Sarah, and I'm currently a surgical PA here at Boston Children's and co-coordinator for the Biventricular Repair Program. I've trained in a surgical fellowship and had additional adult cardiac surgery experience prior to joining the Boston Children's team about 3 years ago now. I work primarily in the OR, first and second surgeons, as well in the CICU, or the intensive care unit, where our patients recover post-operatively. And with me today, I have Dr. Eric Feins. He is one of our pediatric cardiothoracic surgeons here at Boston Children's Hospital. He's actively involved in all aspects of congenital heart surgery, but with focuses in neonatal heart surgery, heart valve repair surgery, and along with this program, the complex biventricular operations. Most of his research efforts focus on reducing the risk of heart block during complex surgery for congenital heart disease, which is a significant problem, especially in our biventricular repair patient population. And this brings us to our topic of discussion today, which is the development and use of electrophysiologic mapping, also called EP conduction mapping, in the operating room. So welcome, Eric. First, we kind of like to understand and get an overview of what exactly this EP conduction mapping is. So do you mind giving us a brief overview of EP mapping and what it means?
Yeah, thanks, Sarah. I'm really thrilled to be able to talk with everyone today about conduction mapping, which has really become a critical part of the biventricular repair program. Mainly just because of what value it adds to the repairs that we do. So we'll go through step by step some of the major components to this effort. But just to answer, Sarah, your question from the outset, conduction mapping really just refers to mapping out the heart's conduction system. The heart has a lot of different types of tissue in it. There's valve tissue, there's muscle, there's also the conduction tissue, which is essentially the circuitry inside the heart that simulates the heart to beat at a normal heart rate and a normal heart rhythm. And so the challenge is making sure that we know where the conduction tissue runs so that we don't injure it when we're doing these complex repairs inside the heart.
And can you describe kind of how this is done in the operating room? What kind of technical steps does it involve?
Yeah, so, basically, just to back up for a minute, we can't see the conduction tissue with our own eyes. So unlike other types of tissue in the heart, like the leaflets of the valves or the muscle itself, or different other structures within the heart, the conduction tissue is invisible to the naked eye. So when we are doing a repair inside the heart, we are basically operating blindly as it relates to avoiding injury to the conduction system. Traditionally, the only way we can avoid conduction is by relying on what we know from historical studies, pathology studies, the literature dating back several decades on where the conduction system runs for certain types of congenital heart defects. So when we are operating inside the heart, while we can't see the conduction system, we're referencing, historical data. And that's okay, but it's not very precise. And it's also in no way patient specific, because each patient, even if they have a certain diagnosis or a certain anatomy, is going to have some slight variation to where the specific conduction system is located. So the goal of the conduction mapping is to really make this patient-centered or patient-specific surgery, so that we're not operating on a child based upon historical data, we're operating on a child based upon that child's data. And so when we do conduction mapping, what we're essentially doing is using a catheter to collect the electrical signals that are generated inside the heart. And so what happens is the catheter, which Sarah is showing here, this is a figure from a publication we put together. The catheter is shown in the upper right corner, and what you can see is it's kind of like a grid. It has, this is the end of the catheter. The catheter is actually about 100 centimeters long because it was originally designed to be used in the cath lab by the electrophysiologists. And so what you can see on the end of this catheter is it almost looks like a fly swatter. And the letter number coordinates refer to different electrodes. So you can see there's sort of little silver bars along the upper, in this upper right picture that are actual electrodes. So A1 is an electrode, C3 is an electrode. And so what we can do is we can hook up this catheter to a special recording system. And with the recording system, we can then, with the heart opened and beating, once we're on the heart-lung machine, we can put this catheter along the inside surface of the heart. And that's shown in the picture over to the left. So this is for all of the patients that get complex biventricular repairs, we will create a patient-specific 3D model that is made for that particular patient. And that model helps for a number of different reasons. A lot of it has to do with just the surgical planning, where we're going to put patches, how we're going to visualize certain parts of the heart. But what we can also do is annotate where we find conduction. And so this model shows a sort of a schematic of the catheter that's being placed inside the heart. And what we're actually recording when we put the catheter on are these funny lines down in the bottom right, which are you can go back to the other slide for a second, Sarah. These are called electrograms. It's almost like if you saw an EEG for someone. It's recording the electrical activity that's picked up by the catheter as it's placed inside the heart and moved around. And so when we're doing this, it's a very closely orchestrated and collaborative process between the surgical team and the electrophysiology team, or the EP team. And what's happening is on the operative field, we are moving this catheter around in the areas of interest, trying to figure out, is conduction here, yes or no? Is it here, yes or no? And the output, the signal output, which is shown on the right lower, is being interpreted in the operating room in real time by our electrophysiology colleagues. So they can look at these signals and say, we see the conduction tissue in this particular area, or we don't see it in this particular area. And so while it's not actually creating a visualization per se of the conduction tissue, because it's invisible, we are still able to, it's almost like a metal detector. We can start to hone in on exactly where conduction is for a specific person. And then once we're done with it, we then proceed with the actual repair that we planned on doing.
And how long does this usually take overall in the surgery?
Yeah, that's a great question. So it's variable, but I would say roughly 5 to 10 minutes. It depends a little bit on the complexity of the anatomy. There are some children with very complex congenital heart disease where the location of the conduction system is highly variable. And because it's highly variable, it's more unpredictable. And in those cases, we may spend a little bit more time doing the conduction mapping so that we can really hone in and get a really good sense of where the conduction tissue is located so that we can avoid injuring it. There's other cases where even if the anatomy is complex, based upon our experience, we have a much better sense of where the conduction tissue is going to be located. And in those cases, it can take, as little as 1 minute to just confirm that it's in the location that we're expecting. But overall, when you look at the entirety of the surgery, which takes several hours, this is only a few minutes at the beginning, but really reaps huge dividends.
So kind of like you alluded to, we're not necessarily performing this in every cardiac patient, more so the complex patients where it's not guaranteed where exactly conduction will be. Can you tell us a bit more about kind of that history and when we started mapping these complex patients?
Yeah, that's a good question. So we've now been mapping patients since the winter, spring of 2020. And the real driver for why we started this is that, the complex biventricular repair program has been going on for a number of years now. And like any program, as it's growing and as it's developing and advancing, we're always looking at what are the Achilles heels, what are the kind of things that we're still struggling with, even if we're making a lot of strides as a program. That doesn't mean there aren't things that we could make better. The conduction system is really one of those areas that we felt we could make a meaningful improvement in our overall management and treatment of patients who come through the BIV program. If you look kind of at all comers in the BIV program historically, this is going back a number of years, the rate of heart block in those kids undergoing these repairs is about 15-17%. So in some ways it seems not too bad. 85% of kids don't suffer from this, but if I told you that nearly 1 in 10 or 1 in 5 children will have a problem related to injury to the conduction system, that's a significant thing that we could really make an improvement on if we put our minds to it. And just to back up, the concern we have if we don't know exactly where the conduction tissue is located is that we could injure it. That injury can happen as we're sewing in a patch to close a hole in the heart. We're often creating what we call baffle pathways, or sort of tunnels inside the heart to direct blood from one chamber out to another area of the heart, and that requires a lot of suturing and patching. Sometimes we're actually it sounds counterintuitive, but we're actually removing some muscle inside the heart in order to open up pathways so that they're not narrowed. And so anytime you're doing this sort of stuff, you run the risk of injury to the conduction tissue if you're not careful in those areas. And so if you injure the conduction tissue, what you've done is you've disrupted the ability of the heart's own system to transmit the electrical signal from the top of the heart down to the bottom of the heart. And so if that signal doesn't transmit, the heart won't beat at a normal rate, and it's referred to as heart block, which is referencing the blocking of that conduction pathway. And so, if a child is in heart block after any cardiac surgery, sometimes it recovers on its own. It's almost like a sprained ankle. It's not permanently injured. It just takes a few days for the inflammation and for things to recover. But sometimes it doesn't recover. And when it doesn't recover, and that conduction pathway is permanently injured, and that is permanent heart block, that's when we need to then put in a permanent pacemaker, which essentially is a small device that replaces the function of the heart's native conduction system. So it picks up the pacemaker kind of picks up the signal that's being generated at the top of the heart. And since the heart's own tissue won't transmit it, it then transmits that signal to the bottom of the heart to kind of create that synchronized movement of the heart. But we do know that, pacemakers, while they've made tremendous advances over the last several decades, are by no means a freebie. And there are sequelae of having a pacemaker, and that's the goal, is to try to avoid that. So we started this 3 years. The long answer to your question is we started this about 3 years ago, 3.5 years ago. And the impetus for starting it was saying, look, we have a non-trivial number of kids who, even though we're really thrilled that we've been able to avoid a Fontan or avoid single ventricle palliation, which we think is a very important thing if we can, some of these kids are still being saddled with other problems that we should try to improve upon.
Thank you. So we've kind of talked about what conduction mapping is and how it's done. And you just alluded to why it's so important to essentially avoid heart block, avoid a pacemaker, and maintain the heart's natural synchrony. So kind of now that we understand all of that and our overall goal to avoid injury to this conduction system, can you talk a bit about the results? Have we been successful in avoiding these injuries?
Yeah, that's a great question. So we have been successful. What we have found, we've now mapped about almost 300 patients in a few years. So it's really been a rapidly growing program within our institution. It went from something a few years ago that was kind of a new novel thing to now it's essentially a routine part of any biventricular repair. So what we found is we're collecting the data is that there are certain subgroups that we're really making a meaningful difference in. One of those subgroups is the heterotaxy population. Now, not all kids who come through the biventricular repair program have heterotaxy syndrome, but a lot of kids do. And heterotaxy is one population of patients where the anatomy of the heart, the structures in the heart is very variable. And as is the conduction anatomy. And while there are historical studies to suggest where it would generally be located for certain types of defects, we're talking about highly variable things, a lot of factors going into it, and it can be very difficult for a single clinician or a surgeon to kind of piece it all together, integrate and say, well, based upon this anatomy, we know that conduction is going to be here. And so the heterotaxy group is a group that's really had a dramatic improvement. So historically, our rate of heart block following a biventricular repair in a child with heterotaxy syndrome was about 14 or 15%. And now it's like 2%. And so we've had, maybe one or two incidents of heart block in the heterotaxy population in the last few years. So that's been one group that's really benefited quite a bit. There are other groups where it's still very helpful for the operation in terms of helping the surgeon plan the surgery and guide the repair. If you kind of run the statistics, we haven't seen a statistically significant improvement in some groups, but some of that's because the numbers are a little bit smaller right now. But I think some of it also is because even though the current methods and the current devices that we're using to accomplish this are a major step forward from nothing at all, we still have a ways to go in terms of innovation with the devices to really tailor them to this specific application. So I think, there are groups, especially the heterotaxy population, that are really enjoying some benefits from this. And as we continue to develop the methods and the tools for this, other groups are seeing improvements as well.
And do you have any published data if anyone's interested in kind of reading more on the technical data from your results?
Yeah, so we have published this. There's a couple of papers that are in the journals out there about this. Kind of the most recent and the biggest one was published about a year and a half ago on our first about 130 or so patients who we had mapped. And that really that paper was meant to show a couple of things. One is that we did see a significant increase, significant improvement in the conduction, in the rate of heart block in those with heterotaxy, which was one of the findings of this paper. The other important thing that we are trying to do now as an adjunct to this is that, as I mentioned, every patient virtually every patient who gets mapped has a model made, much like the one that's shown in this picture here.
Yeah, I can show some examples as well as
Yeah, that'd be great.
for you.
And with that model, we are able to annotate where the conduction system is located. And so this is just an example model of a complex patient looking. This is the viewpoint is how the surgeon would see the heart. So it's a little hard to interpret if you unless you've done these surgeries, but we can annotate where the conduction tissue was located based upon the mapping that we did. And from that, then we can start to generate some patterns. So, it's a little hard to glean a lot of insight if you've only mapped like 3 patients or even 30 patients. But once you start mapping a couple hundred patients, you can start to say, well, for this specific type of anatomy, we tend to see conduction running in one location or another. Or for this specific anatomy, 75% of kids have conduction running above the VSD and 25% have running below. And it doesn't mean that we don't want to map the next patient that we operate on, but it does help with anticipating where conduction will be. Now, again, there are papers out there that talk about where conduction might be located for certain anatomies, but these historical papers, they're based upon, and they're very elegantly and very nicely performed studies, but they're histopathology papers. They're usually focused on 10, 20, maybe 30 patients generally. And there's some wonderful findings from it, but you can't really start to do sort of real pattern recognition. So what Sarah is showing here is a table that shows just a smattering of some of the models from patients that we've operated on and we've done mapping in. And what we're really starting to do is create essentially like an atlas, a digital atlas of where the conduction tissue is located, for certain types of anatomy. So that now, in the past, if we operated on a child with complex congenital heart condition, we might say, well, anecdotally, we generally have seen it here, or if you kind of read the papers, it's kind of sometimes here. Well, now, if we're operating on a patient with a certain type of congenital heart defect, in the BIV program, we can actually pull up and say, okay, where's conduction located for the 15 patients with similar anatomy? And it's a much more formulaic, much more systematic way of planning an operation when you have this type of data. So the interesting thing about this effort is that not only is each patient getting information for that operation, but that information is then feeding into the database to inform future operations as well.
Well, thank you. All these results seem very promising. So I think on behalf of everyone here, we want to thank you for your research in this area and taking the time to discuss this with us. For more information on EP mapping, anyone listening can visit the Surgical Electrophysiology Program webpage, and this can be found on the Boston Children's Hospital website. Also, the recording of this discussion will be available on the BCH YouTube page that you can subscribe to. Otherwise, thank you for listening, everyone, and thank you, Dr. Feins.
Yeah, it looks like there's a question in the regarding the relationship of the models with the mapping. And so just to clarify the current workflow, the models, you're correct, the models are made prior to the surgery. The models are made based upon the, when a child gets a CAT scan or an MRI as part of the preoperative workup. And so what we do is we have the model projected in the operating room. And so in that regard, what happens is that the surgeon can be looking at the model and the electrophysiology team can be looking at the model. And it's not to the point where the catheter actually automatically registers so that you can see the catheter live on the model, but we can at least use it as a reference point to say, look, the catheter is, we have the catheter kind of down in that area. And then if we know where conduction is or isn't, then what we do after, right after we've done the mapping is our team will then manually annotate the model so that we can then plot out where we found it. It's sort of like if you took a map, you were on a trip and you took a map, and each time you drove, you kind of plotted out where your route was. So it is a manual process. It's not automated in the sense that, people can that in the sense that the data is automatically just on there. It does require a manual entry, at least at this current phase of the effort.
Thank you, and we welcome questions. And if there's any more, I can't think of any right now, you can always post in the comments on the Facebook page, or also on the YouTube page. Actually, we just got one more in, kind of a follow-up question. And he's asking, is this EP mapping a standard in complex heart surgeries and other centers in their BIV repair programs, or is it unusual at other centers? Can you comment a bit about how this works spreading?
Yeah, that's a great question that we hadn't addressed yet, so I'm glad you asked. So right now, we're the only center that's routinely doing this. It does take a little bit of infrastructure to set up. You have to have the EP mapping equipment. Now, I will say that all the equipment we're using, none of it is particularly none of it is like atypical for a standard electrophysiology team. So it's all equipment that most centers will have. But it does require, a coordinated effort between the surgical team and the electrophysiology team. So it's not just like you can't, unfortunately, just right now at least flip a switch and just start doing it. So it does require a little bit of kind of a ramp up. There's been a lot of enthusiasm in the community in terms of the congenital heart community, surgeon wise, about doing EP mapping. And so we have met with a number of centers to discuss, their adoption and implementation of mapping, because the reality is that, we want to be making these repairs better, not just in Boston, but, everywhere that they are being performed. So at its current state, EP mapping is not being performed routinely at other centers. We're actively working with other centers to try to help guide them through it so that they can, all the lessons we've learned along the way, they can kind of take and develop the program. So it's still kind of in the, I would say that the last couple of years has been sort of the ramp up development within Boston. And I would say within the last year or so has been sort of the slowly growing, and not slowly, but rapidly growing enthusiasm and slow adoption of this, to the point where the hope would be, as other centers pick this up, and start doing it, it'll become a much more, a widespread thing. But right now it's something that's we're really the only center that's routinely doing this in all BIVs.
Thank you for that. I don't see any further live questions. So if any further questions arise, feel free to comment wherever this video is posted. And our team will be sure to forward those questions to myself or Dr. Feins. Thanks again for everyone for listening. And thank you, Dr. Feins, for joining us this morning.
Thanks so much, everyone. It's been really wonderful talking about this effort. It's been really exciting element, or within the BIV program. Obviously happy to answer any questions that people may have that come up after this webinar. But hopefully this has helped to give people a little bit more of an understanding of this important part to the BIV program. So thank you.